Great. It looks like the recording is now live.
Okay, thank you. Thank you everyone for joining today. We're here today for Section 45 Hospital Draft Rate Reform for distinct psych and SUD units. Next slide, Mandy. Sorry. As David had indicated previously, please share your name and information in the chat for today's meeting. During this meeting today, we're going to go over the rate determination process overview, the draft rate methodology adjustments, and rate proposal overview. We'll also at the end go over our next steps for this section of policy. Next slide, Mandy. The scope of this determination work is to update the reimbursement for distinct psych and SUD units that are currently listed in Section 45. The current rates are the same for all psych and SUD units, except for 3 have unique rates. During this process, we are going to eliminate the inequitable provider-specific rates for distinct psych units, and all hospitals would share the same methodology. Next slide, Mandy. As we had discussed in our December meeting, the reason for the process we're following is the Public Law, Chapter 639, which took effect in August of 2022. We are discussing distinct psych and SUD units, and what we're doing in this process is we met in December 19th to have a provider kickoff and review the draft methodology and discuss some of our definitions for psych and SUD units. We had a submission date of December 23rd to submit comments for the psych and SUD units. We're holding our presentation today of the draft base rates and draft methodology adjustments. We will provide a comment period that the comments will be due January 27th, 2023 this year. By February of 2023, we're hoping to have a department review of comments, finalization of rate amounts, and we have a target date of April 1st, 2023 for the effective date for these rates. At this point, did you want to add anything, Michelle, before we move on to the next slide, or?
Yes. Is it okay? Can folks hear me? If you can raise your hand or nod your heads rather. Thank you. Sorry, we are in, even though all the conference rooms are supposed to be the same, sometimes they're not all the same, and that creates technical difficulties. So thanks everybody for your patience. I just wanted to acknowledge that the April 1, 2023 target effective date, we recognize that that is ambitious. It is still our aspirational goal. And I did want to share that our claim system, some of you know that our vendor Gainwell runs that for us. And we are reviewing with them some new concerns they have regarding systems implications of the methodology in terms of timing. We were hoping to have an update for likely timing today, but we don't. So that is the caveat, is that obviously any methodology we need to be able to implement. And so I wanted to let folks know that that assessment is ongoing, and we will update you when we are able. I also wanted to note, if we could go back to the previous slide just for a moment, please. Thanks. So for folks who have not been through this process before, and again, it's a new formal process, so that might be quite a few of you, I wanted to share that our general approach is that we focus on the methodology as well as the rate amounts in this presentation. We do not focus on provider-specific impact. And that is for a couple of reasons. One is that we believe that it is appropriate for us to focus on whether the general model is sound and reasonable, and we don't want provider-specific impacts to drive our overall policy, especially when we've started with a policy that is inconsistent as well as inequitable. The other reason why we do not share provider-specific estimated impacts is because, especially with this methodology where there are lots of puts and takes, the individual provider impact can vary a lot based on patient acuity for the year, obviously utilization, length of stay, and any projections that we make are guesses at best. So with those caveats, I will turn to Mark from Burns and Associates to, in alignment with my last comment, show how we see some big changes in utilization and costs from time to time. And this probably will not be a surprise to those of you who have been experiencing this on the front lines, but we thought it would be helpful to paint that overall picture. Mark?
Thank you, Michelle. I'm Mark from the Burns and Associates Unit of Health Management Associates, helping the state out with the analysis. We can go to the next slide. So what we did is we looked at the Medicaid specific utilization, mapping the DRGs under CMS's MS-DRG system for mental health and separately for substance use disorder diagnostic groupings. We looked at the cost reports that each facility submitted to OMS for whatever their year end was ending in 2019 compared to the same cost report data for their year ending in 2021. We used a methodology that CMS has used and published in its final rules for mapping cost centers to cost report lines to assign a cost to each discharge within these DRGs. And we looked at the original payment amount versus what the cost was for each case, as well as some of these other attributes. So at a high level, starting at the top, when we segregated the discharges for Medicaid specifically between mental health DRGs and substance use disorder DRGs, you can see that across the 2-year period of utilization, that in fact, the mental health discharges actually dropped a bit, 3.5%, but the SUD discharges, the number increased significantly over just a 2-year period. Although the mental health cases went down, the total days went up significantly, as you can see, by almost 25%. And the SUD days also went up, but that is generally in alignment with the number of discharges. So when we take the average length of stay for any given case for mental health, it was an average of 8.1 days for a Medicaid beneficiary in 2019, and it grew to 10.4 days in 2021. So that's an increase of 29%. Whereas for the SUD cases, it was generally steady. So as you can see, the theme here is that not much of an increase on volume for mental health, but a large increase in total duration of stay. And for SUD, not so much a change in the duration of stay, but a significantly larger volume. Then on the cost side, when we look at the cost per discharge, the cost for mental health cases increased substantially over 2 years by 41%. And as you can imagine, a lot of that is attributable both to cost increases overall, as well as the days increased for each stay. And SUD also increased, but more moderately. So at a cost per day analysis, mental health went up almost 10% and SUD went up about 4%. But that being said, the SUD cost per day is still coming in higher than the average mental health case cost per day. Next slide, please. So I wasn't sure whether I was doing this one, David, or did you want to take?
Okay, did a mute delay there. Thanks, Mark. I'll pause for a moment just to see if anybody had any questions for Mark before we go to the next slide. Okay. All right, so last time we met, part of the conversation we had was around the current definitions of the SUD and psychiatric distinct units. And I have a general update.
Oh, I think you muted. I think you muted.
Okay. Do I need to back up? Yes. Okay. So as we discussed at our last meeting, we shared the current definitions for distinct psych and distinct SUD units and asked for feedback related to those definitions. We didn't receive too much in the way of feedback. And so our general approach is going to be to clean up the language somewhat, but our objective with that cleanup to that definition is just to reflect current practice. And so it shouldn't result in any substantive changes. One substantive change, however, since our last conversation, or development, I should say at least, is that we, in this proposal, are proposing to eliminate the separate rate methodology for distinct SUD units. So as we said at the beginning, right now there are two different rates, one for psych units, one for SUD units. The SUD rate is actually lower than the psych unit rates. We only have one operating distinct SUD unit in the state right now. And as we'll talk a little bit more about later on, we actually, based on the hospital cost data, we see that the costs are higher for patients with SUD diagnoses. So one, we don't think it makes sense to have a lower rate across the board for those SUD units. And I would also share that, as Mark will speak to more, the DRGs and our proposal as a whole reflect cost differences in the population. So we'll have a single reimbursement methodology that will account for cost differences between members with primary SUD diagnosis versus psychiatric diagnosis, but that same methodology will apply to both kinds of units instead of having different approaches to each unit. Any questions about that? Okay, we'll proceed. Back to you, Mark.
Thank you. So this is actually, from a formula perspective, not changed from what was presented before, but just formally showing you that the formula that CMS is using for these same cases in a hospital setting is a per diem rate times a DRG relative weight times a length of stay factor, and the state is proposing to use the same formula for the Medicaid program as well for these particular cases in these DRGs, and it would be used for both freestanding psychiatric facilities and just, well, the formula here for Medicare, excuse me, is used for freestanding psychiatric facilities and distinct part units within hospitals. Next slide. So I don't know whether state team are you?
Yeah, Mark, we're having delays, so thank you for your patience. So Mark is going to talk through the three main components of that methodology. The first component is the per diem portion, and I'll provide one update here, and then I go back to Mark. So last time we met, we had indicated that our goal was to achieve 100% of cost coverage. We had provided the caveat, both when we were talking through the slide as well as in writing on the slide, that that goal was contingent on hospital confirmation of DHHS identification of the distinct units, as well as general alignment of associated main care reimbursement. That sounds a little jargony. That gets to some of what we discussed last time, is that the difference between inpatient stays in distinct units versus, I'll say, general inpatient stays has not always been so clear in practice as well as in our claims data. So we had asked for some assistance in kind of comparing what we understand as reimbursement for distinct units with hospital understanding of those distinct units. We had only received feedback actually from one hospital to that regard. And so we have some concerns about the data from that perspective. I will also restate, as Mark shared on the earlier slide around utilization, when we updated the analysis with the 2021 data, utilization, especially the SUD discharges and the mental health length of stay, has increased sharply since 2019. Costs have increased sharply as well. We still will be expending the fully appropriated amount for this initiative, but we are now looking at covering 80% of costs instead of our initial goal of 100% of costs. Again, we'll be spending the same amount, but given the change in utilization and increase in costs, it's not going to get us quite as far. For context, I will share that, and all of these numbers are in aggregate, that we estimate current cost coverage to be about 60%. And so moving from 60% to 80% is still a very significant increase. I will also offer the caveat that some of this analysis is fairly late breaking, so we are planning to conduct further analysis of 2022 data to look at utilization trends. We also welcome further responses from hospital in terms of our request last month to kind of look at our understanding of the cost compared to, or rather, our understanding of reimbursement for these services compared to hospital understanding of the reimbursement. And if we feel like we can bump up that 80% cost coverage and stay within our appropriation, then we will do so. Any questions on that before I go back to Mark? All right, quiet group. Go ahead, Mark.
Okay, thank you. So within the Medicaid proposal, the OMS proposal for this reimbursement methodology, just to lay out the clear distinctions between their approach and Medicare's, it looks very similar, but some nuances. There would not be a local wage adjuster applied here as there is in Medicare. In other words, any hospital eligible under this methodology would receive the same per diem base rate as the starting point, whether it's for mental health or SUD cases. There would also not be an age or comorbidity adjuster. That being said, the proposal is that there would be 3 different per diem base rates. And the rationale for that was because of the variation we saw in the cost. So the first distinction is the first sub-bullet is that there'd be a distinction in the per diem base rate between mental health and SUD services, with the SUD per diem starting point being higher than the mental health one because of that cost differential. Now, in both cases here, because the formula is the per diem base rate times the DRG relative weight and then the length of stay factor, the base rate is still going to be adjusted for acuity depending on whatever DRG assignment, either within mental health diagnoses or SUD diagnoses. And then we also saw a difference in the cost between youth and adults within mental health. So the proposal is to have a different per diem rate within the mental health DRGs for youth versus adults. So that gets us to the 3 per diems, 1 for SUD for all population in Medicaid, and then within mental health, 1 per diem for youth and 1 for adults. Next slide, please. And here are the actual rates as I just described. So you can see the SUD one is quite a bit higher because it was found that those costs were higher than in the mental health space. And it was found that the adult cost per day, which is both the cost per day and the length of stays tend to be larger there as well. When all of this is put together, that achieves the 80% cost coverage distinctly for SUD and then distinctly for mental health using these particular per diem rates and the 2021 utilization data. Next slide, please. As a reminder, this has not changed from the last presentation, but OMS is proposing to adopt Medicare's 2023 relative weights for each of the individual MSDRGs that would fall under this methodology. So in the box, the last 4 rows are the SUD relative weights, and all the ones up above that are the psychiatric mental health DRGs. And you can see that with the exception of 886, which is actually not billed very often, the Medicare 2023 relative weights are higher than the current one. So that is the proposal to adopt the weights in the far right column. Next slide. And then finally, the other component to the formula is the length of stay factor. And this has also not changed in what was proposed last time. These factors are the factors that are published by CMS in its rate setting methodology for these services. And OMS is proposing to adopt Medicare's length of stay factors and the approach used here as they also use it. I believe that's my section. I think we're ready for the next slide and whoever is presenting next.
Thanks, Mark. This is David again with MainCare. Part of our presentation last month, we got the question of how will these rates be maintained and updated on an annual basis. So we are still working on the exact solution to that, but we have outlined here the general approach that we will be taking for those annual updates. First, we will be doing some work to identify the appropriate inflationary index that we can use for that annual adjustment. That index would be applied to the per diem rates that Mark just presented. Those per diem base rates would be updated annually, inflated proportionally to that index, and we would also stay current with however Medicare is updating their DRG weights and their length of stay adjusters. We would just keep current with those weights and those adjusters that are associated with the length of stay. This means on an annual basis, we would not be re-examining costs or utilization data to do a complete rebasing. That complete rebasing would be done on an every 5-year schedule. And that will help us keep up to date on any changing cost structures or any major shifts in how these services are being delivered. And I think that's all for that slide.
Any questions?
Any questions on the annual update portion before I move on to next steps? Yes, Jeff Austin.
Yeah, thank you. So that I'm clear, the number that you plan on starting with in calendar year 2023 is based on the cost data from 2021. Is that correct?
Yes, that is correct.
Okay. To give you a heads up of what we would probably advocate for is that given that 2022 was a unusually and historically high inflation year, we would strongly feel that 2023, the first year, you should adjust that 2021 number to account for 2022's nearly 10% inflation rate, so that we're getting out of the gate not so far behind. But that's an advocacy position, but we would just ask you to consider that. If 2022 had been a normal year, could probably look the other way, but it wasn't when it comes to cost. So just something to ask for you to consider. Thanks.
Yeah, thanks for that comment. We'll definitely take that back, and we'll take that into consideration as we're completing our utilization analysis for 2022. Any other questions? All right, so for next steps that we have laid out here, as we've discussed, we will be continuing to do utilization analysis with more current data and looking at potential projections for what we might expect utilization to look like in the current calendar year and into the future, to see if that changes our thinking about the exact percent of costs that we could cover with our proposal. In the meantime, though, we will be formally collecting your comments on this proposal, and we welcome your comments in writing for about the next 2 weeks through January 27th. And you can send those comments to Jessica Levesque in rate setting. Her email is at the bottom of this slide here. She is our project manager for this effort, and she'll be collecting and aggregating those comments. Following that comment period, we will be taking some time to review your comments and taking any of those comments into consideration, developing our responses to comments, and finalizing the rate proposal that will reflect the final rates. As Michelle mentioned, we are targeting April 1st as our effective date, but that may be impacted by the systems impact analysis that we're currently undertaking with our vendor Gainwell to make sure that this methodology can be implemented effectively in our system. The time frame may shift depending on what we discover with Gainwell. Furthermore, we are still working with our policy group to review the current definitions that are stated in policy, just to tweak or refine those if we think those are needed to cover the list of hospitals who are currently being reimbursed under the discharge methodology. We want to make sure that we're keeping up to date with those definitions. We don't anticipate that any tweaks to those definitions would impact the providers who are currently being reimbursed under the current discharge methodology that is stated under current policy. I did see a few questions come through in the chat, and I don't have those up in front of me. Can somebody?
There's just one question asking about slides being made available, and Amanda answered that the recording and slides will be available within the next couple of days.
Great. Yes. So these materials and this recording will be posted to our rate reform website. If you are interested in seeing those materials, you can go to maincare.gov/rate-reform, and you will be able to see the slide deck posted at that location. It may take us a little while to get that posted, but it will be up and available publicly. Jeff Austin, I see your hand is raised. I don't remember if that was just from your previous question or if you had another question.
Thanks. No, I have one other quick technical question on the meaning of effective date. Sometimes you allow sort of retroactive billing back to a previous date. When you say effective date, do you mean like truly effective? The new rates would only be applicable for claims beginning after, let's say, April 1. Is there any retroactivity anticipated, or no, you're just effective date means claims going forward only?
You are correct, Jeff, that when we say effective date, oftentimes that may end up being retroactive. In this case, there are considerations that there may be considerations we need to discuss with the Office of Attorney General. So and rulemaking. So I can't answer the question at this point around whether these can be retroactive.
Okay, thanks.
All right, any other questions about the content of this presentation or the process that we are undertaking? Feel free to raise your hands and we can take your questions as they come up. And if there are no questions, I'll just repeat that we will be collecting your comments over the next 2 weeks. So please take some time to collect your thoughts, offer up your comments or any questions you may have after the fact. Again, you can share those comments in writing with Jessica, and we will collect those and prepare our response to comments accordingly.
And I will just also repeat the invitation that, and we can resend out the question, but when we, for each hospital, we shared main care's tabulation of reimbursement for these units and would like answers from additional hospitals as to whether that reimbursement amount aligns with your own understanding of what you consider to be your distinct unit reimbursement for main care, just acknowledging that sometimes we've seen some inconsistency in how things were billed. And so it's not as straightforward as you would necessarily anticipate to do that assessment on our own. And that could have an impact on our ability for percent of cost coverage. All right, well, thank you everyone for your time this afternoon. We appreciate it.
Thank you so much, everyone.